Yay! Look, okay, crossing my fingers. You know, it's been some weeks since I put this together. Oh, look at God. Look at God. All right, all right. How are you? I know. Somebody had posted, I was looking through comments from previous YouTube videos, and they were like, well, where's Mr. I said, I miss my friend. I know. She was like, I miss y'all. I was like, I miss us too. How's it going? Yes, yes. Don't let them work you to death. Oh, well, look at God. Look at God. All right, all right. Well, let's get this party started. Let me get rid of this ticker here. Okay. Yes, yes. Okay. Well, let's get the party started. Good morning, everybody, and welcome, 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 welcome. Wait a minute. Let me put this over here. You know, I'm a little rusty. It's been 2 weeks now. Let me get my whole life. So welcome to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, pretty much anything that just pops off the top of our head related to healthcare. I am Clarice Warner. I'm the girl with the pearls. I see my name changed on the thing. I didn't want it to do that, so I'm gonna have to fix that over here in Clubhouse. But anyway, I am the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key, where I provide consultation services for the revenue cycle, for compliance plans, for all of the things. I'm your girl. And do you know what it takes to be a certified marketable medical coder? Do you? I know some of you do. But if you don't, before I introduce my co-host, let me share with you information on a free 99 email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
So if you are in Clubhouse, feel free to click the link at the top of the house. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder. If you are on YouTube, Facebook, and LinkedIn, you can check out the video description for the link. And trust me, it's in there. I promise you, it's down there. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been in healthcare for a long time. During the pandemic, I created a company called Coding Nurse, LLC, where I help nurses and other healthcare professionals with the clinical background transition into the wonderful world of HIM.
Yes, and you're doing such a wonderful job in that. Yes. I tell you, the nurses, I think most of them know, those who have interacted with you and taken your courses, gotten advice, gotten direction, gotten guidance from you, know the gem that you are. And so I know it's my personal goal is to get other nurses who may be involved or considering transitioning to connect with you, because you are definitely a gem and you have a lot of information to provide and help them in that transition. So that's a personal goal, to get folks' eyes on you. All right. So let's see. Before we jump in, let me remind you that if you are on Clubhouse and want to join in and add to the conversation, please raise your hand. We'll be monitoring, sort of, kind of, the room. Um, and don't be shy. Come on in, talk to us. Your opinion matters and is welcomed here. For my Facebook, YouTube, and LinkedIn friends, you all know what to do. You know to use the chat. If you have a question, place a Q first so that we know it's a question for us and we don't miss it. So today, for those of you who are joining us, we are talking about some a real hot topic, the Chat GPT and health information. Yes, yes. So if you're unfamiliar with Chat GPT, it is actually um, a platform um, that brings us closer. So we've talked about AI before, and this is kind of a little taste, dipping your toes in to that automation where you can ask questions, um, you can do all kinds of things. Let me just say that. Now, but there's some kickers to it, and we'll talk a little about some of the kickers to to this platform. But it uses and it tries to make things easier. So if you have questions about like how to process um uh not medical coding, but like coding, like HTTP or JavaScript or something like this. It will provide you some information. If you want to, if you say you're hosting a gathering or some type of get together and you want some ideas, and so you go out and ask it, give you some ideas on the best um, uh, 60th birthday party. It'll generate ideas. It'll scour the interwebs, I guess, and provide you with some ideas. If you ask it about, and I've used it recently just to ask a whole bunch of stuff, and it'll give you some things. But what I've noticed, and we'll talk about that a little bit in a minute, that you got to read the information that it presents. You got to make sure that it's on the up and up. So one of the reasons why we are bringing this to your attention, and let me just say this before I get into healthcare, because it has been also a hot topic in education. And I think when I thought about it, the academics are not necessarily happy about its use because students have been using it to generate their papers and all of the things. And so I think somebody did a whole law brief or something recently. I heard that was like, they said was like excellent. So it benefited in that way, which made the academic folks not necessarily happy. But then I thought about, there is a kettle and pot situation, because they use AI to check plagiarism. They use an AI system to actually verify that there's no plagiarism, that the quotes are correct, and all of that. So I guess it's okay for them to use it to check that, but not necessarily okay for students to use it to generate thoughts and ideas. I don't know. I just thought that hit me when I was thinking about it. Like, well, wait a minute, they using it, so why are they trying to say it's all bad? But anyway, turning to our world, we wanted to talk about Chat GPT in healthcare. And there were a couple of articles that talked about using Chat GPT for for discharge summaries. And yeah, so one article, I'm trying to pull up the articles, I'm sorry. One article kind of was for it, I guess. But they also mentioned, the limitations, and even the program tells you of its limitations. So it only knows things, and let me pull this up so you can see what I'm talking about. I got that'll be, I think that'll be better.
While you're doing that, Clarice, LaShonda got new on YouTube. She changed her name. She's the crafty coder.
Oh, did she? Okay. That's what's up. So she's starting the whole crafty coder thing.
Good morning.
That's what's up. I see her. I see her. Good morning. Oh, I love it. I love it. You better work your business. Work your business. Okay. Let's see. Chrome tab. Okay. Yeah. All right. So you can see some things over here in the chat, but it tells you, so the limitations, that it may occasionally generate incorrect information. It may occasionally produce harmful instructions or biased content, and it has limited knowledge of the world and events after 2021. But it says it remembers what users said earlier in the conversation. So you can actually have like a conversation, a back and forth dialogue. So if they give you some information, you can further probe and give it additional instructions. It allows users to provide follow-up corrections. That's kind of where I was going with that. And it's trained to decline inappropriate requests. So I thought, let's kind of take a look at this article. I'm doing all kinds of things here. You can see. Look at this article. So it asks, is ChatGPT appropriate for discharge summaries? And it was from Dr. Erica Reamer. If you know anything about like ICD-10 Monitor or RAC Monitor, she's a regular on that program, and she provides commentary, usually from a physician's perspective, on all kinds of stuff, coding, regulation, just all kinds of stuff. So she's one of their regulars. I think she's been on there for years. So she talked about, in this article about an issue where they had a pregnant patient who had passed. And of course, this initiated an investigation in Ohio by the Ohio Department of Health. And what happened was, of course, when those investigations are initiated, records are then requested. And usually they want records right now. Not something later on. They because it's fresh, they want to make sure everything is complete, etc. So one of the things that they found out was that they didn't necessarily have all of the documentation that was needed. And so she made a comparison to Joint Commission, who requires the discharge summaries be completed within 30 days. But others policies could potentially be more restrictive. Like your facility policy could be more restrictive. In this case, the Ohio Department of Health's policy was also more restrictive than that 30 days. And so they were given 2 weeks to get all of their discharge information and summaries completed, because they had unfortunately a track record that their discharge summaries were not complete timely. So not only did that investigation trigger information related to that particular case, but low-lying fruit, they found out, well, y'all got a bigger problem. Y'all got a problem in not getting your documentation completed timely. So This started a windfall. They had about 1,200 incomplete discharge summaries, and some of them were old, like years old, and some of them were still in paper form. Some of them were from providers that no longer were part of their institution. They had a whole conundrum, if you will, of issues. Um, and so they really had to buckle down and begin to dictate and write these discharge summaries. Of course, for smaller lengths of stays, it was a little easier because you can go back, look at something. You didn't have as much paper you had to go through, but then some of them were lengthy. The one thing about some of the lengthy ones, and especially some of the ones that were years old, and I don't know if she put in here when this actually happened, but with the paper records, the only issue she kind of ran into was having to decipher some illegible handwriting. But remember, with an EMR, think about all the copy, cut, and pasting that is happening in that. And so all of the additional stuff that has been repeated over and over and over again would be kind of a nightmare in one of these situations. So let's see. So I think IT came up with kind of something to overlay on their electronic medical record that could possibly assist in maybe going through, quickly scouring the record and reading the information that could put together a discharge summary in a little bit of time. This was where she kind of thought about or added to her conversation ChatGPT. And there was also a larger article that was published in the Lancet that also talked about the use of technology, AI technology, in putting together discharge summaries. And she said the sample they gave seemed rather generic, but it was an uncomplicated total hip replacement surgery. And one might imagine that perhaps it was reflective of a routine hospital course. And so it would have been interesting to see ChatGPT tackle a complicated ICU case. Now, I don't know what kind of examples, sir, you got, but but we'll see. So overall, I think you got two thoughts. One, that I think even the government thinks this, or have been under pressure to think that documentation is a burden for providers. And they are always talking about lessening the burden for providers related to documentation. But really, I think, and others in the profession, and even other medical professionals, think that documentation isn't a burden. Really, it's part of your job. It's part of what you do in medicine. It's to quote Dr. Reamer, it's a responsibility. Documentation is what details the medical care that has been provided for that patient. It is clinical communication. It is everything. It is the starting and ending of all things related to someone's medical encounter. So I don't think it should necessarily be looked at as quote unquote a burden, but when folks think it is, or trying to find ways in which to assist them in this burden, open the door to things like AI and ChatGPT. The thing that scares me the most about it, which like I said, I've used it for different things, is the inaccuracies that I found, even in the little things that I've done. But the one thing I did learn is that you have to be very, 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 very specific about your request. The more specific you are about the request, the better the results. So I'll step back. I'll let you jump in.
I think when it comes to ChatGPT and discharge summaries, that's a definite no. Because from from somebody who has to read discharge summaries every day, the problem is not ChatGPT. The problem is these providers, because right now everything is dictated. It's not like they sit there and write.
Correct.
They use Dragon for everything. My issue with discharge summaries is, especially when it comes to longer stays, like short stays are easy peasy for the most part. But when you have longer lengths of stays, providers do not rule out conditions. Your discharge summary is supposed to wrap up the entire hospital course. Matter of fact, they have a whole section called hospital course.
Mhm.
If something is suspected, it should be either confirmed or ruled out.
Mm-hmm.
So many times, I have to send queries to see whether something has been ruled out or if something is clinically significant. That's the majority of my queries. Because, first of all, a lot of times hospitals are in such a rush to get the bills done that in some instances, as a matter of fact, I had a case just this week. I'm like, where is this coder getting this documentation? Because I went through all of the notes and I couldn't find it. So I called. I talked to my preceptor. So he said, go to incomplete. Come to find out, the discharge summary was incomplete, and the coder was took the documentation from the incomplete discharge summary. So my preceptor was like, well, you're not supposed to code from incomplete. It has to be signed before you can use a code from any kind of provider documentation. But what happens a lot of times is I have a lot of cases that have to be rebuilt, because what happens is when I send a query, because there's a different timeline if you send a query if somebody's inpatient versus once they've been discharged. Mm-hmm. But there's a timeline, and once the timeline is expired, the coder can go ahead and drop the query, basically ignore the query, code it how they see fit, and submit it. But that still doesn't mean that my query is done away with. I'm still waiting for, because I have a totally different job than they do. Mm-hmm. So I still have to wait for this provider to respond. Mm-hmm. A lot of times when the provider responds, that can affect the coding. So then I have to contact the coder and they have to recode the case and then rebuild it. So it's a lot that goes. ChatGPT will not make that process any easier. So I don't think that it's going to be effective.
The scary part to me is, I'm laughing at the crafty coder. You are absolutely correct. It's like, first of all, I ain't coding nothing the doctor didn't sign. You won't get me wrapped up. Every girl, she is telling the truth. So the one thing that really struck me was, first and foremost, we have documented evidence of issues with provider documentation, hence the whole CDI initiative. So if there are issues with documentation, how you got issues even before the discharge summary is written. If you're using the AI process to then generate a discharge summary, that discharge summary is doomed to fail before the ink dries. I mean, because the information that you have, oftentimes there hasn't been a query, there hasn't been any corrections, there hasn't been anything, and so you got bad coming after bad. And then so the coder gets this. That just really makes more work on the health information professional, because then you got to validate, you got to take it. To me, I would think a system worth its weight would make sure that somebody is validating this AI generated documentation to make sure that everything is okay. But then you have the additional step with CDI to validate that the information before it even hit the discharge summary was accurate and correct and complete. So I agree with you. There's a lot of additional steps that this quick 5-second discharge generated this AI generated discharge summary is now causing on the back end. So is it really worth it?
Because the whole it's so much that goes. I'm just so grateful that I have a position where I can really see the real inner workings of the revenue cycle, especially in inpatient, where cases are in the thousands, tens and six figures, amounts, and to see how it works, because so much time is wasted on a lot of. I understand why, to a point, why physicians get annoyed with queries. Because, case in point, I had a case, this was about 2 weeks ago, clearly acute on chronic, diastolic, whatever kind of heart failure it was documented. The coder sends me a query, sends me a note and says that we should query because it's not acute, it's chronic, because the person did not receive in her mind, if you don't have a chronic, you don't have an acute heart failure situation if you don't have IV Lasix. That's not the only criteria.
Right.
So I said to her, I said, well, it's clearly documented that it's acute on chronic. And the person was on PO Lasix in the hospital. The person had some kind of kidney injury. So when you have a kidney injury, you don't want to give a person a lot of fluid because that puts a burden on your kidney that's already stressed for whatever condition's going on. So I didn't want to send it because I'm like, it's just pointless to send a query. So she wasn't going to let it go. So I said, you know what? I'm not trying to go back and forth. I sent the query to the provider. The provider validated the same code that was already documented in the medical record, acute on chronic. But that's what she needed. Like, I don't understand. Like, that's not a hill to die on. Like, that's, who cares? Because it's not my job to challenge a doctor on why they coded something. I just have to make sure that the documentation is there and it's a valid document.
And it supports it.
It's
right.
Documented.
Right.
That's it. So it's a lot that goes on behind the scenes. That's crazy.
And to your point, that is kind of where the coding staff requires some education and training on, what's appropriate to even take back. That don't waste our time. that's sometimes your skills should determine what your next steps are. And clearly that was, you got 3-4 folks eyes on a piece of paper that shouldn't have been in the first place.
But what they don't send a query for is deep tissue pressure. Now you should want somebody to send a query about that.
Right. So I'm saying, so there should be, and maybe that's a training or in-house training or communication for these organizations where I know we talk about educating the provider about, seeing the same types of things that require queries, but then also maybe the coding staff needs to have some training as well about, these are some of the things that we are looking for queries regarding. And so if you see any of these, make a note that, hey, double check. And if you don't see what is needed for this particular condition, then, reach out to your CDI department and have them generate the appropriate queries or whatever. But I think there's appears to be an opportunity for training on both sides. So it's not just the provider, there's some additional training that happens with coding too.
Yeah, exactly, Lashonda. He said what he said, and I agree. But now the longer length of stays and the more complex cases will be very, very interesting how they handle it because they're going to make ChatGPT a thing. They're going to.
Yeah, it's coming.
Doctors' mind is going.
They're like, yes. They were like, okay, here we go. Here is proof. They've been using it. They're testing it, the whole shebang. So they're ready to run with it.
Because they already use AI and computer assisted coding anyway. I see it every day. And sometimes they're right, sometimes they're wrong because I still use the book. It is what it is. I still use the book, and sometimes when I look at the codes, the PCS code might be right, but to a point, but it's the wrong approach. So if it's the wrong approach, then it's the wrong code.
It's the wrong code.
So, or they might use the computer assisted coding might recommend an unspecified code for laterality, but when you read the note, it clearly says right or clearly says left. So once again, that's the wrong code. So it's really, really not quite there yet. And I don't know when it will. Eventually it will, but not right now. So this is going to be interesting.
It is. So anyone in the room or on any of has any of you had any experience with using ChatGPT that you want to share? Do you have any thoughts one way or the other regarding she's so silly. She said PCS is a beast. Get someone else to do it.
I like it.
I mean, once you know those have a great working definition and familiarity with those concepts, it's a breeze. But that's the challenge, is getting there.
Shirley has her hand up in Clubhouse, so I sent her an invite.
Okay, I see she got the fist. But anyway, well, she can come on up if she wants to. Oh my God. Not right on. Oh my goodness. Yeah, so that was pretty much, kind of our thoughts. And I'm like you. I believe it is coming, whether, regardless of anybody's opinion one way or the other. I just think okay, what's your song?
Ready or not, here I come.
Yes.
And I.
That's right. Oh. We got a song. We got our song. I agree. I believe it's coming. And, I think it's really, really important that hopefully these conversations have already begun, but that their conversations are being had by all of these departments, and they can't be working in silos because it's going to touch everybody. That, what parameters are we going to put? What quality assurances are we going to put around this? What additional validation are we going to put around this? The training for these providers, because they can't just be doing, or they shouldn't just be doing any old thing out here and thinking that this is going to be great. Because you got to think about, at least in my mind, I always try to think about, well, what is the end result on the back end? Like, yeah, we get the money, we get paid, everything is done. It's 2 years later, then what? Then all of a sudden it has become a problem. Did we do did we outline and define what our parameters are? And did we stick to that? Based on, what the current guidance was at that particular time. So I think it's now that we know, ready or not, here it comes. Just being prepared, taking the time to really talk through the strategies on how to use this system. And so again, it's totally different from, I think, our conversations related to using like the computer assisted coding. This could be you. This could be you in a hospital and having, a course and then having something that's totally incomplete, or that could potentially jeopardize a lot of things, because if something's not right, they're only going by what's documented, and that documentation goes a long way. That documentation could impact or hinder insurance coverage, all kinds of things. And so it's really, I think, important and to everyone's benefit that they really be strategic about how this new tool will be used. Yeah.
Definitely.
Yeah. Okay. So I know we talked about, and I want to put you on the spot. Did you have we talked about the first day of Black History and the last day of Black History.
Let me tell you, I could not find anything about Black HIM, but I did find out that it started during the Black Plague. And once I couldn't, I mean, it was nice to know, but once I couldn't find any specifics, I was kind of like,
okay, well, we had something Black in it, I guess,
And I'm surprised that, like AHIMA doesn't have any kind of, they didn't put anything out. I wonder if they just don't know.
I don't know. I don't know. My term. I met with my executive director just this past week, because we're very strategic about what we're doing during my term. So there's a couple things that I want to see change, and a couple things that I love, and I want to see it maintained and even double down on. So we are planning my whole year as president of OHIMA, and so yeah, we had a long conversation related to that. So hopefully, I can make some little difference in a year, something. Something in a year that will be lasting and impact those coming behind us. So I'm excited about that. So what else we talked about? Did you read the other article about the social determinants of health?
Yes, and I have a case that we just talked about yesterday.
Okay, well, tell us about your case.
What is so interesting is social determinants of health is really going to become a thing.
A thing.
Currently, which I did not know, so a social determinant of health cannot be a principal diagnosis.
Correct.
Although I don't know, I think it might need to be, because this particular case, this person was discharged. They have, they're oxygen dependent.
Mm-hmm.
When they got home, when the ambulance took them home, they realized that their electricity had been turned off.
Mm.
They had even their backup tanks were empty. So they had no oxygen. So they had to come back to the hospital. So of course, once you've been discharged, you have to go back to the ED and all of that. So the patient was in observation. Long story short, the person was in the hospital for 4 days. That's too long for observation. They admitted her inpatient. They tried to come up with a condition that they could kind of like validate her being there, but the insurance company was having none of it. So,
none of it.
So the claim got denied, it got escalated, it got denied. And I'm like, there has got to be a way because surely if she were to go home with no oxygen, it could be fatal, very life-threatening. So why can't the hospital recoup some money or some kind of way for this? Because you can't stay in observation for 4 days. You just legally can't, according to policy. So what is supposed? So it's interesting that the hospital would have to take a hit for this condition for this particular case.
So was it new? Was she just now? Has she been or had the patient been on oxygen before, or is this a new?
Yeah.
Because I'm thinking rehab maybe, or a long-term care facility. Maybe. I mean,
you know how long it takes to set people up to transfer from a hospital to a SNF or to a nurse. It takes sometimes a week based on availability, the paperwork. You got to check the insurance, all of that.
but then that gives you time in that facility. I mean, it's valid because then you're in the process of transferring them over to the other facility versus.
Right, but you still need a cause to be in that bed.
True.
You still got a bill.
True. Well, or charity care. Here we go. Yeah, she said another reason for the insurance companies to raise hospital copays. I've always, because what used to frustrate me, and I still don't hear this conversation loud enough as it relates to social determinants of health. Because, the provider's contention was, well, it's not giving us additional revenue. But it does. If they think about, if you're adding this information, to me, this information adds to the story. It provides additional information as to the medical necessity of reaching out to this person and getting this done, and the case management stuff that goes on with these various patients, whether or not these patients are compliant with the treatment, the medication, all of those things, because of these additional factors that are occurring at home or in their life. So to me, it builds the case of why this patient, there's an increased level of medical decision making that has to go on with these patients because of these external factors that are happening outside of, but impact the condition that the patient has. To me, that's dollars. That's dollar signs. That's where the money resides. So while if I add this code to my claim, no, it's not automatically generating additional dollars. However, if I add this code to my claim, it's providing additional confirmation and information about why these things are done and the medical necessary reasons that these things are done. And I don't understand why those types of conversations are not being had with the medical communities to get them to understand the importance of having that information documented.
But I think that there still needs to be a way for this to still be billed and payable. Because if it affects it, if a social determinant of health affects a person's life, which is really why you capture it, because there are a lot of extenuating circumstances that go into care and that affect the health of the person. So once we have defined it, okay, it's nice to define it, it's nice to have a code for it, but if you can't ultimately be paid for it or not take a loss, because what's going to end up happening is that people have to if facilities have to take a loss, they're going to stop doing it.
But they shouldn't, because again, if they use it to justify the treatment, the again, medical decision making that they're doing, then that's how they're getting paid.
But they're not getting paid because the case got denied, so they had to eat all that money.
Well, in that case, that's different because you were in a hospital bed. So I'm provide. You know me, I'm provider based.
But that's what I'm saying. But there are a lot of people who really can't. I mean.
But see, you got to think about a hospital. So maybe there needs to be some step down, because a hospital right now, the way medicine has evolved, a hospital is strictly for acute care, period. So all of these other entities that make up or revolve around the hospital should then be part of, well, what happens in instances where this woman is on oxygen? She clearly, or the patient, I keep saying woman, this patient is on oxygen, clearly requires electricity, doesn't have any. where do we go? What do we do? But if you think of, and so I don't necessarily fault the insurance companies for that, because again, this is just for acute care inpatient. And to your point, the observation period, I mean, you can't play the rule is the rule. And you can't necessarily play with that. However, again, you got to be a strategic thinker on, well, how do we utilize XYZ space, or how do we utilize other things, knowing, especially if you're in an area where your patient mix has a lot of these social determinants that could potentially happen to them. If you are in an area where you know, okay, this is a clear possibility, we see this all the time. How do we help our patients help themselves? How do we help our patients continue on with the treatments that we provided to get them healthy, to get them back to, a baseline or a stable level? Because ultimately it's creating a cycle, because then they're going to come back to ER, and then it's going to be, it's a whole cycle. So you really just got to think through, how do you handle that? What can you do, facility, organization, to kind of offshoot that? And then there has to be some policy written. There has to be some additional conversations about, well, insurance companies, when we sit down and negotiate, we all know this is a real thing. This is here to stay. What can you do to make sure and offset, the cost? Maybe sit down and work together and think about, okay, well, no, we can't do XYZ or house the person in the hospital, but is it fair that we house them in this level of care? And let's create what that level of care looks like for those types of conditions or those types of things that come up, so that they get paid to do what they need to do to stabilize that patient and whatever, and then have the additional community resources or whatever they need in order to get, whatever that social determinant rectified, at least for that patient in that particular condition. I don't know. I'm thinking through. I don't know. But I mean, it just has to be, because to your point, just eating a $10,000, $20,000 case, that's not fair for them. That's not fair. Well, the patient, if that patient ain't got electricity, they ain't paying that $20,000 bill. So it's like, and you can't turn them away, because when they come into emergency, you can't turn them away. And Tala says, no, you will not be turning them away. So again, it's a revolving door. And at some point, somebody has to say, hey, how can we stop this revolving door? What can we do to get this person on a right course?
It'll be interesting to see how it plays out, because it's going to be, these kinds of things are going to become more prevalent as you have people who are living longer and more people are living alone.
Yes.
Now more than before.
Yes. And just, so the one thing, we went to LA, and I had never been to LA. And I'm glad I'm not in LA now, because it's cold and rainy. It was cold then, and I was complaining, but the cold and rain, oh no, I couldn't do. But anyway, and they were talking about snow and all kinds of foolishness. And I was like, are you crazy? This is supposed to be a warm vacation. But anyway, so one of the things my husband wanted to do was to, he's a photographer, and he wanted to take pictures of the various murals of Kobe Bryant and Nipsey Hussle. And so I me, I strategically put together a plan that we had an Uber take us all around. Like, our Uber was our travel guide. And so we got the addresses of the different places, and we went around and we saw whatever. So one of them happened to be in this block of area that is affectionately known as Skid Row. I was unfamiliar, to say the least. I was unfamiliar. Now, we have a homeless population here in Cincinnati, but the one thing about here, you see it's more prevalent in the warmer months, but you got to think California is warmer all the time, usually. When I tell you this stuff went on for blocks and blocks and blocks, and the structures and there was one part. So I got a picture. I maybe I'll post it somewhere. I got a picture. Dude had a hot tub, an inflatable hot tub in his inflatable home that was on the block. I was like, for real? Like, folks need love too. I said, see, this was doing way, way, way too much. They had, so you had one area, and it was during the daytime, so you didn't see a lot of people. But then you had this other area. It was like the Carter. It was like, it was people like just in the middle of the street, like just out there, gone, just gone. And then one of the Uber drivers was telling us that, I was like, well, around the area, you saw a lot of social service organizations, that help the home. They even had, which I thought was cute. They had, there was this park that had movie night, and it was like Skid Row movie night. Like, so on Wednesdays or whatever, they show like a movie for everybody to come, and so they were trying to even have like social gatherings and social areas for the people. But the Uber driver was telling us that they pay them, and I don't know if this in California, I'll just say this, or I don't know, in LA, they actually pay them not to be homeless, but pay them as homeless or unhoused or whatever. And so, because the question was, well, can they, do they get a job? And it was like, well, some of them just are checked out. And it's like, why go through the hassle of keeping track with rent and this and the third and all of that when you're gonna get this money every month? You get food every month because they give some kind of, it was a whole kind of stipend thing. And so, I mean, people are literally just, that's their whole life. That's their thing. So to see that and think about it from that social aspect, but then from a healthcare aspect, what happened? So all I could think about was like COVID. Like, think COVID. You got these people who are back to back in some boxes. So I mean, and these are some very crafty. You talk about crafty folks. Like, they got hubcaps, they got metal from cars, they got whole structures like built up to keep the elements out. Because if it's warm, it's hot. So you got sun during the daytime, you got rain, you got all. I mean, they didn't put all kinds of stuff, but they're close together and close, areas. And then on the Carter side, that's a whole other conversation. But on the Carter side, they're out here with drugs, so that's a whole drug area. So like you had levels to Skid Row. Like, you had the one of my family members used to be like the upper poor. So you had the upper poor, you had the middle poor, you had the lower poor. So there was levels to it. But just think about like all of the potential issues that can happen from a healthcare perspective, and those social determinants of health impact what could potentially happen when they engage or become part of the healthcare scene. And it's like it's a real thing that somebody need to consider. and all of it, because it was a lot. I was blown away, just blown away.
Well, if I'm not mistaken, I think that Skid Row is about, it's got to be close to like 50 years old, somewhere around there, because I think it started in the 80s.
Mm-hmm.
And what people see, like, people don't pay enough attention to social policy and its long-term impact. Because in this country, we are great we are famous for blaming the victim.
Mm-hmm.
We create a situation, people fall victim to it, then we blame them for falling victim to the circumstance that somebody else created. And that somebody else is Ronald Reagan. Because because there for years and years and years, we had these things called, they used to call them asylums, then they called them institutions, psych hospitals and institutions. There was a time when you could not be on the street. And Ronald Reagan was the first person to stop that. And then it developed nationwide. So he closed all of their mental institutions. So where are you supposed to go if you're mentally ill?
And it's a lot of that everywhere, nationwide. It's everywhere. All the cities I've visited, it's like, who is helping these people?
Nobody, because the majority it's a proven fact that the majority of people who are homeless have some form of mental illness. That's documented. So then you have a lot of people who use drugs to cope.
Mm.
So it's just a vicious cycle. I think that it has always been cruel. It has always been heartless. And people talk about, how great of a country the United States is, and it's not. Because it's horrible when you have when you have billionaires who, with one check, could could clear Skid Row for years and still be billionaires, but they don't do it because they don't care. And you have you have government officials who don't care because they don't work for people. They work for the billionaires and for the corporations, who basically none of us matter. And it's a horrible situation. But there is a direct cause, and it's policy by heartless people,
Mm.
and it's not going to change.
Yeah, I was at a webinar yesterday, or seminar. It was at the American University. This is a whole other topic, but to your point about policy, it was talking about health and equity after Dobbs, and it was off the chain. Woo! It was off the whole entire chain, and just eye-opening perspectives from just a whole bunch of academics and attorneys and public health people, and even healthcare providers. And the one lady said, we're sitting here, we're scratching our head, we're asking all the questions, and we continue to ask the question. And he's like, but you know what, we do have the answer. And if you just insert racism into every question that you ask, then that's where your answer lies. Like, well, why are we doing this, or why did they do this, or what? Racism. Why did they, and the whole room just hushed. I was like, oh my God, it really is just that it could all be so simple.
The two isms that this country will never address is race and class.
Class, yep.
Everything comes down to race and class.
You're right.
Race trumps everything, but classism is second.
Yep. And all of these policies just, yeah. And it's unfortunate. It is.
Because then you have these people who, like in California, it's a hotly contested, and they even have a name. Because you have they do sometimes, cities want to develop, like they want to build transitional housing for the homeless, or they want to build what they call them, they have different names, like transitional housing.
Mm-hmm.
I'll just say that. So you'll have people who will get together in these communities, and they will protest the development, and they'll go to city council and complain. And they're called NIMBYs, which is not in my backyard. So they don't want transitional housing anywhere near they live because of the type of rent, and then they claim that it's going to decrease their property value. So everything is about, well, we want to help, but it's not here. So, okay, so if not here, where?
Exactly. Well, I hate to wrap it up on such a Depressing, no. Yeah, but information is information, and it's food for thought and things for us to consider, because even in our world, in our profession, it impacts what we do. All of those things impacts what we do.
I mean, oh, it does. I mean, I've had cases where you have people who have like there are a lot of people who are, they don't call it, I think the correct word now is unhoused. They don't call them homeless.
Mm-hmm.
But yeah, unhoused.
Mm-hmm.
And you can tell, like, you see these 60-something-year-old men with cellulitis, and like the pictures of their legs are horrible. But they have not received any treatment. And then they're going to patch them up, and then they're going to come back in a couple of weeks. Like, it's an endless cycle until, and it's just, it's sad.
It's very sad. It's very sad. Okay. Well, on that very sad note, well, this has really been eye-opening on a lot of fronts, even from talking about, ChatGPT and what that use in health information is going to look like, social determinants of health and health policy, and how all of this kind of runs together in the circles. I mean, it's all related. It's all relative and all related. So thank you all. Thank you all. Even though you were very quiet today. Thank you, LaShanta, though. You weren't. Thank you all for joining the Saturday morning tea. Was the tea spilled today? It's a different kind of hot tea, but yeah, I like that. If this information was valuable for you, help us share this message with others by liking the video, sharing the video, share, and subscribing to the channel. I am on a personal goal. I'm trying to get to 10,000 subscribers by the end of the year. So tell a friend to subscribe to the channel. You can also check out the Coding Nurse channel on YouTube and subscribe to him as well. And last but certainly not least, to my Clubhouse folks, click on the greenhouse to join the fun in our club, and you will be notified of our live broadcasts that occur every week, Saturday mornings at 9 a.m. Eastern Standard Time. So this has been a great session today. A lot of thought, food for thought, and things to kind of ponder on and think about as we do the work that we do, and how things impact what we do, but also how what we do impacts others. So think about that. Thank you for joining. Did you have any last comments, words?
No, just once again, I always thank you for creating a space to have this kind of dialogue and this kind of education.
Yes. Well, thank you all again for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care and talk to you soon. Bye-bye. Bye-bye.